Good morning. On behalf of my co-principal investigator, Dr. Jennifer Temmel, and our research team, I'm extremely pleased to share the results of our large-scale comparative effectiveness palliative care trial. The main takeaway from this national multi-site randomized study is that palliative care led to equivalent benefits for patient-reported quality of life, whether delivered via video or in-person visits among adults with advanced lung cancer. The study findings underscore the potential to increase access to evidence-based early palliative care through telehealth delivery. Despite considerable advances in novel therapeutics, most people with metastatic lung cancer will at some point along the disease course experience burdensome physical and psychological symptoms as well as impaired quality of life. To address these unmet needs, national guidelines from ASCO and other professional organizations recommend integrating palliative care from the time of diagnosis of advanced cancer. These guidelines are based on evidence from multiple clinical trials demonstrating the efficacy of early palliative care for improving quality of life, mood symptoms, coping, and other key outcomes in this vulnerable population. Unfortunately, most patients with advanced cancer and their families do not receive this evidence-based care due to multiple barriers, chief among them being the limited availability of specialty-trained palliative care clinicians and practical issues in accessing supportive care. One promising solution for helping patients overcome obstacles to obtaining medical care is the provision of telehealth using video visits, which has accelerated dramatically since the onset of the COVID-19 pandemic. Healthcare leaders recognize the benefits of telehealth for improving access to supportive oncology services, and recent studies have shown the utility of telehealth for reducing healthcare-related costs in patients with cancer. So while many healthcare facilities now have the capacity to offer video visits, whether the virtual modality is as effective as in-person care for improving patient outcomes remains unknown. Our team therefore conducted a comprehensive comparative effectiveness trial to answer this key question, with the primary aim to evaluate the equivalence of the effect of delivering early palliative care via video versus in-person visits on patient-reported quality of life in a sample of 1,250 patients with advanced non-small cell lung cancer and 548 of their caregivers. The enrollment period went from June 2018 through May 2023, during which patients with advanced lung cancer were randomly assigned in a one-to-one fashion to receive either video visit or in-person early palliative care. 22 cancer centers throughout the United States participated in this trial. Both study groups followed the same protocol in terms of having a palliative care visit at least once every 4 weeks. Participants completed outcome measures of quality of life, satisfaction with care, and mood symptoms every 12 weeks up to week 48 post-randomization. Of the 1,250 enrolled patients, the average age was approximately 65 years old, slightly more than half were women, and the majority self-identified as white, not Hispanic, and married. The two study groups were generally well balanced with respect to sociodemographic and clinical characteristics. To assess quality of life, patients completed the Functional Assessment of Cancer Therapy Lung Scale, or FACT-L, and higher scores indicate better quality of life. For this primary outcome, equivalence was established if the 90% confidence interval for the estimated difference between groups was within the equivalence margin of plus or minus 4 points on the FACT-L. As shown here, we demonstrated the equivalent effect of delivering early palliative care via video versus in-person visits on patient-reported quality of life. In terms of secondary outcomes, we found that caregiver attendance was higher in the in-person group compared to the video visit group. You can see in this table that caregivers attended about half the in-person visits and only about 37% of the video visits. The two study groups did not differ with respect to patient and caregiver-reported satisfaction with care or patient-reported anxiety and depression symptoms. Thus, we confirmed our primary hypothesis in demonstrating the equivalent effect of the two delivery modalities for early integrated palliative care on patients' quality of life. Furthermore, we observed a significantly higher rate of caregiver participation in the palliative care visits among the in-person group, likely due to the need for family members or friends to accompany and assist with transportation to clinic appointments. Finally, the study groups did not differ with respect to other key outcome measures of satisfaction with care or patient-reported mood symptoms. These findings add critical evidence to support the ongoing access to telehealth services, especially for vulnerable populations with serious illness, and will ideally inform policy decisions regarding the role and coverage of virtual care in the future. Nonetheless, questions remain about the circumstances in which video visits ought to be the preferred modality for delivering palliative care, especially to reduce the burdens of travel, costs, and risk for infection among potentially immune-compromised or frail patients, as compared to when in-person visits are essential. Follow-up interview studies with patients, caregivers, and clinicians would help answer these important questions. Finally, further research is needed to increase representation of patients from diverse backgrounds in telehealth studies and to conduct subgroup analyses to determine whether the intervention effects vary based on key sociodemographic variables such as age or other factors like technology experience. I'd like to express my immense gratitude to all the patients, caregivers, clinicians, and research staff who took part in this trial, as well as my co-PI, Dr. Temmel, and our investigative team. Finally, I would like to thank the Patient-Centered Outcomes Research Institute for funding this study. Thank you.
Thank you, Dr. Greer. I'll now ask Dr. Charu Agarwal, ASCO expert, and Leslie M. Heisler, Associate Professor for Lung Cancer Excellence and Director of Precision Oncology Innovation at the Penn Center for Cancer Care Innovation in the University of Pennsylvania, to make a few additional comments about the significance of this research.
From this study, we see that early palliative care can be delivered successfully, effectively, and efficiently using telehealth in patients with advanced lung cancer. Early palliative care is an integral component of delivery for lung cancer care. Now, we have the technology to reduce the burden on patients and use it to our advantage. Findings from this study underscore the importance of telehealth in improving access and broad dissemination of palliative care for patients who otherwise may not be able to get it. Integration of early palliative care will improve quality of life and lead to improvements in survival for patients with advanced lung cancer. Thank you.
Thank you, Dr. Agarwal. You may be aware that ASCO has issued a series of guidelines on the integration of palliative care into standard oncology care, first published in 2017 and just updated about a month ago, I think, really reinforcing the importance of integrating palliative care at the time of an advanced diagnosis into standard oncology care. So I think this telehealth model is an excellent way of trying to serve our patients who are at centers that don't have palliative care, who can't travel, et cetera. So this is one way of achieving ASCO's recommendation to early integrate palliative care for our advanced